I'm very glad to be here to talk about this important issue. And I want to go into some details beyond the big picture that late has been provided, and also my colleagues, Kamran and Arash, presented from maybe 1 decade ago what happened and what was what happening in the just beginning phase of the epidemic and starting the fight against this new coming epidemics to Iran. And I may consider myself as a kind of second-generation researcher or second-generation surveillance response to the epidemic. And I would give some updates about the ongoing activities, the size estimation of the sex workers, what we expect to see, how many sex workers we expect to see in each country, what is the total sample size, population size, and what is the risky behavior about this if we consider them as high risk, how they are risky. And I would give some examples about what would happen to the general population in terms of transmitting these infections to other people who are connected with these high-risk groups. And I may give some examples about mortality, losing people on follow-up when they are getting positive. And I will have listed five challenges to actually respond to this epidemic in the region. And I would give some examples about how to deal with these challenges. And I would be happy to hear from you in the panel discussion we would have in 1 hour to talk about this and maybe future steps. Okay. So when we talk about MENA, we're talking about 23 countries, but basically we're talking about people who are at risk for this HIV. So when you go to the numbers, even I just put all these small numbers to mention that these are people who are at risk. One could be me, one could be you, or any friends of you, or any families, or any people who are living in this country. So in terms of people at risk, I mean, we are talking about 150 million men who are sexually active in the region, and about close to 100 million women who are sexually active and living in the region. And this is the distribution, heterogeneous because of the different population size we have in the country. And it's just a kind of guesstimation what we're talking about as a population at risk. According to the percent of female sex worker, percent of people who are doing, who are saying sex among women who are 15 to 45 years old, I mean, my guess is we have about 93,000 female sex workers in the region if we go with the lower global trend or prevalence of the female sex worker in the world. So it's, as you see, it's very, the prevalence of female sex worker according to the region is vary from 0.1%, means 1 per 1,000, as Late mentioned, to something about 10 or 7 per 100 prevalence in the world. And if we go with the lowest figure, the global lowest figure, we would have something about 93 female sex workers almost in the region. And this figure shows us it's very according to the region. And this is the paper I used to get into this picture. However, about MENA, we are not sure about. Any studies wasn't reported in that paper. Some few papers about size estimation has mentioned kind of prevalence of female sex work in Iran, but I will present that anyway. But also we have a kind of variation in the country. So it's variation by region, it's variation within the country. So mostly female sex work or commercial is urbanized issue, but you can see we have this problem in the rural areas, or we have a problem mostly in the capital cities, and we have this problem might or somehow less in the other urban areas. So, but still, we don't know any about rural areas. In Iran, we didn't go to the rural areas to do this kind of surveillance in rural areas, but we focus on urban because we want to get as much as possible from those, focus on the most affected anyway. And if we go with clients of female sex worker, if we use the global figure, which is 2%, or it could be 9% according to the definition. I mean, if we're asking about men, if you paid for sex in last year, it could be about 2%. If you ask about, did you have sex in exchange for money gifts in last year, it could be about 9%. So many different, huge, difference between these two. But if we get 2% and apply it for the region, we would reach to about 13 million, 2 to 13 million clients of female sex workers living in the region. It's a huge number. And if we go just smoothly distribute this among the countries we have over there, we can see according to the population, Pakistan, Iran, Egypt has a kind of high. I mean, it has so many assumptions that is homogeneous distributed, but the total number is, at minimum, is about, we're talking about 3 million clients in the region. And I want to say just a small study in Iran has mentioned that the figures is reasonable. So if somebody, a kind of policymaker, has a kind of concern this global figures could not apply to my country, I would say we have some calibration studies here in Iran. The percentage of adult, sexual active men who has contact with female sex workers in the last months is something about 2.4 to 5%, according to different methods anyway, but it's trustable. So the range is about 1.5% to 8.2% generally about the adult women. So it's like any places in other the world. It's human. They have some desires. Sex is attractive. Any kind of these things that we see in other regions, it's also applicable for the region. We're not an exception, and this should be the big message we should transfer to the policymakers. And again, this method has been published I just put references over there if you can follow the details. This published in International Journal of Preventive Medicine. And in terms of HIV prevalence, Late has talked about this, and there was a great discussion before this. But anyway, Morocco, between 2001 and 2009, almost the prevalence is stable, about 2%. But from region, sub-region to region, it's about 0.5% to 8.1%. So it just varies over the country. We also have seen this in Iran about. And in 2010, just recent published study about prevalence of HIV in female sex workers in Iran. That study has been done in about 872 female sex workers all around the country in 13 cities. And it's about 4.5% generally, and the confidence interval 2.5, 8.3 is the range. And if you look at the subgroup who has history of injection, this just rise to 11.2%. So I mean, they are linked together. This could be injection-driven, but they also have their own epidemic, according transmitted by sexual routes. And interestingly, Afghanistan has published a recent study in 2013. They have a female sex worker study in 3 major cities in Afghanistan. Even in the situation which is hard to live, they have done this great job to reach to about 500 sex workers in 3 cities. And the study shows that the epidemic is just happening, and it's about 5 per 1,000 to 1 per 100. It's there. And these are some papers that have published, and I got these figures from them. And in terms of, this is the prevalence. So what we are talking maybe makes sense if we talk about the new cases, the incidence. So in Iran, in 2010, we estimated about 10,000 new cases happened in the country by using this kind of modeling exercise. In Morocco, Late has done a great job. It's about 3,500 cases. But the distribution of the cases is just coming by the ongoing risk in the country. In Iran, it's mostly IDU injection driven. In Morocco, it's mostly about sexual routes and female sex worker. And if I want to summarize this, now the estimate of new infections about Iran, about 45% is coming from sexual high-risk behaviors, I mean, unprotected sex. And the rest, 55, are from injecting drug users. I mean, still we have the injecting drug users most affected, but the proportion is not relative to the size, but it's, it's 50% now in Iran we are transmitting by unsafe injection and unsafe sex. It's not appear in looking at the HIV case reported and diagnosed in the country because we kind of underestimated the route of sex transmission. We're looking at the reported data or identified cases in the facilities. But this modeling is just tell us the sexual rate is not limited anyway. If we compare to Thailand, Kenya, and Uganda, if this epidemic just going beyond the female sex workers and what's happening there, the next step is to be more clients and spouse, as Late mentioned, would be affected, and it's coming to the general population anyway. So in terms of the number, I mean, because the size of the general population who are sexually active is huge to this risk population, the crude numbers, I mean, the most frequency would be from the general population. But according to the prevalence, those high-risk groups are affected more and more. Anyway, this findings has published in a paper in SDI and also in another UNAIDS report that are available. You can Google it, very easily find it. For the risky behavior of female sex worker for Morocco, 2008, on average, 4 clients per week. I mean, they are busy anyway, because the price of getting one female sex worker in Iran depends on their area, but it's, if they mostly do this not on favor because they need the money. And if the price is so low, you should be more busy with more clients anyway. But this is the figure. So for Morocco, it is 4 per week. And 60% used condom in vaginal sex constantly in the last months. But when we ask about anal, it's 26. So mostly they are using maybe condom because of the contraception, not the HIV protection. And in Iran also, there is a kind of quality research that has reported that people, sex workers do not believe that HIV could be transmitted through anal sex. So that is a kind of misconception that we have found in the last rounds, and now they're focusing on this kind of gap. In 2010, for female sex workers in Iran, the clients per week was 2.3, and it's ranged from 1.5 to 3. And last sex condom used by paying clients is close to 57%. And for non-paying partners, 36. Non-paying partners could be any kind of, main partner or a kind of friendship relationship. So they don't care. And we lose the chance to prevent further transmission of HIV to actually those who actually they love. Afghanistan in 2006-8, they reported 61% has more than 3 clients per week. Again, the same feature. But the consistent condom use is very low, 11%. So the HIV itself is low. The behavior is high. This is the area the HIV virus, loves to go through this population easily. And if we do not monitor this population, suddenly it would be like a kind of epidemic that we see in prisons in Iran. Challenges. Given the contextual factor that we talk about, social norms, hidden population, all of these things, I mean, addressing, monitoring HIV, tracking the HIV in the region, in the country is a kind of challenge for us who has been working for this. I'm going through and the challenge one, how to estimate the population size of the most at-risk population. I mean, how many sex workers do I have in my country that I should take care? Hypertension is important or sex work? I mean, if you don't know the size, how you can go with planning. So the problem with size estimation, there is no gold standard and no consensus about any methods that we can reach them. 2% or 9% of adults are clients of female sex worker. Which figure is correct? And if you apply both, there is a huge range. No trust. How we can make a policymaker trust these figures if they don't believe? So they will not take any action on when there is uncertainty like this. We don't know which method is the best. We're not able to fully calibrate or correct, and many methods, different definitions and typologies. So we don't have one kind of female sex worker and one definition. If you look at the literature, any kind of diversity you can see. Sex work, paying money, not paying money. Only this will produce a huge difference on the numbers. If you add the time frame or you limit the time frame, another problem. What kind of sex work? Is it brothel-based, street-based, venue-based, home-based, telephone-based, all the things. And how to get them, how to access to them is another issue. So I would say these are about 23, 24 methods has been proposed, tested, and implemented in many global settings. Those reds, I can recall that have been done in at least one of the countries in the region. So network scale-up, capture, recapture, mapping the census, wisdom of crowd, conventional wisdom. These are the methods that have been used to estimate the size. Some of them need to reach to the at-risk population. So you need a kind of survey to get on female sex worker to estimate the size. The other one, like network scale-up, I mean, only you need to go with the general population, ask them, among those, you know how many are sex workers. So it's a kind of indirect approaching. It makes sense, less sensitive, but again, a lot of debate. So in terms of the cost and in terms of the scientific rigor, you can see there is diverse here on the methods. Which one to be choose, how to calibrate, I mean, it's the dilemma and it's an ongoing discussion about this kind of estimations. The challenge too is that how to reach these people. I mean, if you need a study about what's going on, tourism or people coming to United Arabs, how you approach them, where you can find them, at the customs stage or later in the venues, in the streets. That is a kind of another challenge that we have to work with this high-risk hidden population. I mean, household survey, good for hypertension, good for any kind of general question. Do you expect to see female sex worker at home that just show up and say, yeah, I'm doing this sex for a long time, I didn't use condom? It's very, in the context that we're talking, it's very tough to find correct answers to a household survey among general population. But RDS, time location sampling, street walk sampling, again, those red has been implemented in the region, in somehow they works. Some of them are successful, the other one not. So case by case, we should learn about each to improve ourselves on the others. How to measure? Okay, we know it's a problem. We design a study to reach them, and successfully we get them into the session of the interview. How we can get real information from this population, that is another challenge. It's very hard to talk about your experiences with clients or your personal issues, it's always tough. I mean, I have been in this interview, and it's very difficult to put it in a conversation, get some information which is accurate. Anyway, I mean, to give you a kind of sense, basically most of the interviews in the region are face-to-face, interview-based data collection by using a kind of questionnaire, and the questionnaires could be as long as 5 to 20 pages. And let's say this is an example. So, did you use condom in your last sexual contact? The answer could be yes, no. The true could be yes or no again. So, is there any way to find how much they will underreport? Yeah, there is a way. So, if you can use both methods, in-depth interview with routine interview, or you can use some device-based interview. It depends how you can, and you can estimate how much underreport happened to the stigmatized risky behavior. And this is a finding from Iran study that female sex workers has been studied, interviewed in 2 ways. One is routine-based happening interview in the behavior surveys. The other one is in-depth interview with a psychologist. And you can see the gap here. The red bars are those, for example, let's say, ever used drug. If somebody acknowledged that they used drug, if somebody reported that they used drug, what is the truth? So if somebody mentioned that they are a drug user, it's close 100 is true. If somebody didn't mention that they're using drug, it's about 90% they're true. So the gap here is underreporting on not reporting the risky behavior. And you see in having genital ulcer discharge in the last 12 months, underreporting is about 45%. So it's happened. Very usual. Even if you're approaching female sex worker who should not have any problem with, presenting this kind of risky behavior, but still they are stigmatized. Still they have social bias, reporting bias. Be careful about the question. Be careful about the type of interview. Train the interviewers and prepare the setting. Anyway, there is a kind of underreporting happen here. And also about the number of sexual contacts, the number of non-condom use, the number of days per week they have sexual commercial sex, is again underreported. So 1.5 number of clients per week is underreported. Okay, we know that we have a kind of underreporting of stigmatized behavior. How we can, accurately estimate the risky behaviors in a country to make a case for a policymaker that this is the truth, this is the size, you should make this, it's a real problem. If you trust this, go ahead, do something. This is ongoing epidemic in your country, in this region. So how we're going to use this, again, we can calibrate, we can use those information I'm not going to do these details, but anyway, you can find details in this paper, the methods that we can apply to reach to the true prevalence of risky behaviors of female sex worker or any kind of stigmatized behavior. Anyway, if you have the reported prevalence, you have the specificity and sensitivity of those questions, a kind of underreporting, you can correct the reported behavior prevalence to the true prevalence in a way using these methods. And okay, here's the point. The true prevalence is, let's say, I will get an example here. So, when we question female sex workers, do you have any link to any place for having sex or finding partner for your sex working act? Only 35% say yes. If we correct for underreporting, the truth is almost twice. 68% has a kind of link to a place to find or exchanging sex over there. It means There are some venues, and mostly most of the female sex workers are linked to them. We don't know. And maybe those places could be a kind of site of intervention, site of providing testing, site of providing condoms. They are linked to this, but you misunderstood if you do not correct for this kind of underreporting, or you do not approach them correctly. Anyway, this kind of correction could be happen also for the any kind of behavior that's reported as an average. So the number of sexual contacts in 7 days in last week, if it is reported as 2.3 per week, but if it is corrected, it's about 4. So again, we have a kind of underreporting. We should take care to produce accurate estimates and evidence. Okay, when somebody have a risky behavior and tested and become positive and at the end linked to the service, what is the next? How many do we have them linked to the service as they continues on their infection advanced stages? And what is the mortality among HIV positive in the region? I mean, I'm talking about Iran in a specific context. We're talking about HIV positive, about 1,500 cases HIV positive in Iran. And this study was done to measure what is the mortality rate. And the overall mortality rate is 7 per 100 person year. It means if we have 100 positive cases, we follow them for 1 year, we will lose 7 over a 1 year follow-up. According to the global, it's more than the global range for the developing countries, which is 5.5, and it's much more than the developed countries, which is 2 per 100 person year. I mean, even in the capital city of Iran, who has maybe the most accessible to the resources and anything else, we are not doing very good, according to general term. According to the mortality, we're not going to. Also, we have a kind of problem of loss to follow-up too much. I mean, the early loss to follow-up. So about 70% of the people who are infected and shows up at the clinic, they just come for one visit, and you couldn't find them later at any time. And 70% more also drop in 6 months. So basically, after 6 months, you will have dropped about 40% of the cases who are linked to the services. It could be a kind of overestimate because it's a kind of referral center. We try to get to those people, but this feature is not, I mean, a kind of reasonable for the region. Again, this study is accessible in the STD and AIDS journal, but these figures are telling us we have a kind of another challenge to get people in the services and to be linked to the services as they going through the infection. The challenge 5 could be, I think we had a kind of talk about this, insufficient capacity among health workers, practitioners, researchers, peer and NGOs, and policymakers to deal with the above mentioned challenges. We need to be trained for design. We need more capacity building for local who are working in this area. And this kind of challenges somehow addressed, but it's not sufficient at all by some within region institutes and out region institutes. I mean, I want to acknowledge Well Corner Medical College, late from their knowledge hub from KMO University was focusing on HIV surveillance as a second WHO collaboration center in the globe. INCOS for focusing on drug treatment and harm reduction in Iran. International collaborations like Knowledge Hub in Zagreb, we had a lot of things to do together and joint programs. Global Health Science in UCSF, Center of Middle Eastern Studies, Chicago here. I think we should complete this list to have all the partners together to get to the point that we will stop until to put an end to it. And I think together we can do this. And I hope this initiative could be continued with a real practice, research with good implementations. And thanks.
Thank you very much, Ali. Do we have any questions?
Yeah, I was just curious if there was any reports or statistics on the population of, and I'm not even sure the prevalence of this in MENA countries, but the prevalence of the HIV infection in people who participate in survival sex. So not just people who work as sex workers, but people who engage in sex to get food or somewhere to sleep. If there's any statistics on that population of people in the MENA countries.
So you have a specific definition of sex work, which is just
people who
are
making money off of sex versus people who just engage in sex for food or water. That they're not getting paid to do it; they're just getting food, something to eat, something to sleep, things like that.
I mean, it's very critical to them to survive. Otherwise, they would die. I mean, something like that.
Yeah.
I don't have this figure in hand, but maybe the new definition of the female sex worker is focused on the paid sex, and it's focused on money. I think, did you publish that manuscript about the definition of high risk population? It get published?
No,
not yet. Oh yeah, that is a tough question because how you define this population, it just affects the size, the behavior, the epidemic that you're going to present. I myself don't recall any female sex worker study who exclude the money based female sex work from the rest and separate this, but maybe you can Google it.
Does anyone have any other questions?
So you said that there was a problem in that they don't follow up with these HIV patients. They come in once. Why do you think that's happening? Is it because of the fact that both the people who come in and the administration, they just feel they don't want to deal with each other after? Or is it a problem within the administration that it's not equipped to do follow-up?
It's a kind of complex issue. Basically, it could be just underreporting of the system that we have in place to monitor how many people just show up. And, or it could be a problem of if somebody just show up in this center and then continue with another center, if there is if the linkage between these two records could be missed in between, I mean, in the discussion, we had plenty of this kind of discussion. We're not sure about this. But general feeling that I have about this kind of high loss to follow-up is people, when they become diagnosed at the first time, they're registered. And then when the stigma is around HIV, especially among those affected, is too high, they would not continue with that center or that area. They try to be hidden in the other places. Or even they don't go to get the services because they don't want to be labeled as HIV positive in the community. So it could be a kind of pressure of the high stigma around those infected, and it could be a part of our losing in the record or medical records in the system. Yeah.
I actually had a question about accessibility to condoms. I don't know if you could speak about different countries, but maybe you can speak at least about Iran. What is the accessibility to condoms? Is it cost prohibitive? Where does one go to buy a condom, or are there services that provide free condoms to sex workers?
Okay, for this specific group, female sex workers in Iran, we call them vulnerable women. So in the country, they're not labeling as female sex worker among those who are working with them and in the population in general. So by using a kind of acceptable label, we the government has been established more than 45 centers specifying to provide specific services to female sex workers. So this kind of condom promotion, counseling and testing, STI counseling are just in place, they can get to these services through these centers that are scattered around the country. And the condom is free and it's promoted. The problem is mostly the personal or individual barriers that not using them. So it's not the issue of accessibility, availability, it's the issue of the using the condom mostly. Yeah.
Any last questions?
I have a question about how, if you've studied the actual clients of these sex workers and to see the demographics, like their age, like if they're in rural or urban areas, and then maybe you can target special interventions for them to use condoms.
For the clients?
Yeah.
That is, one of the most hard target group that you would have, because female sex working themselves are a kind of open to this discussion because they think they are vulnerable, they would get the services, but clients themselves don't want to be, identified in the community. So that is, the missing parts. We don't know how to approach them. It's not for the region, it's not for Iran, it's globally. Clients are the big, black box, how we could approach anyway. But maybe some kind of household surveys among general population that they have integrated surveys for many other problems like hypertension, and they have incorporated a kind of behavioral section to the questionnaire to talk about this as a combination of the health program, not a specific sex-related behavior assessment. It could be a kind of things, but we had a kind of problem to include this part of kind of questions into the national surveys, household surveys, to be asked from the general population.
I figured it also be difficult as a woman because of condom negotiations. So
Yeah, that is.
coming from the client, so male.
That is a kind of, but it's very hard to target the clients anyway, targets of female sex worker.
We have one more question over here.
Just to follow up with Sammy's question, what's the legal environment for carrying condoms for sex workers and clients? So are there any sort of ramifications in terms of being caught by the police with condoms?
Actually, police is not accusing or capturing those women or men who are having condom in their pockets, and that's not the case in Iran. Yep.
Any last questions? Well, thank you very much, Ali.
Sure.